Welcome, and thank you for joining us. My name is Audrey Hassan, patient liaison for the MDS Foundation, and I'll be moderating the presentation today. Thank you to Bristol Myers Squibb, Jazz, Novartis, and Taiho for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Rory Shallis, Assistant Professor of Hematology Medicine at Smilow Cancer Hospital at Yale, New Haven, Connecticut. Dr. Shallis received his medical degree from Rutgers Robert Wood Johnson Medical School, completed his residency training at Brown University Rhode Island Hospital, and fellowship training at Yale New Haven Hospital. He is focused on the care and research of patients with myeloid malignancies, particularly acute myeloid leukemia and myelodysplastic syndromes. He also participated in the K-12 Calabrese Immuno-Oncology Training Program and currently participates as an investigator in several clinical trials aimed at improving the outcomes of patients with AML and MDS. Dr. Shallis also maintains research interests in epidemiological outcomes and effectiveness research as it pertains to hematologic malignancies, with the goal of identifying barriers to effective care and ultimately strategies to improve the outcome of patients with these malignant diseases. Dr. Shallis has presented his research at multiple regional, national, and international meetings, and is a member of the National Comprehensive Cancer Network Clinical Guidelines for MDS panel. He is an author on more than 50 peer-reviewed publications and book chapters, most of which as first author, and has served as an ad hoc reviewer for many journals, including Leukemia, Blood Advances, and Leukemia Research, just to name a few. With that said, it is my pleasure to introduce Dr. Shallis.
Hello, my name is Rory Shallis, and I'm a hematologic oncologist at the Yale University School of Medicine and the Yale Cancer Center in New Haven, Connecticut. I'm here to talk today about how we understand the precision medicine initiative in the treatment of MDS and to some extent AML. We'll discuss how disease biology, which is a strong factor in this endeavor, translates into some of these certainly relevant missions, including we'll talk about some of the data that we have in support of this from our recent hematology meetings. Here are my disclosures. Hopefully, by the end of this webinar, you will understand that MDS is truly a disease different from patient to patient and biologically similar to AML, which is a disease a bit farther down the spectrum. Because of this variation of biology increasingly being understood with further advancements in the field, it is my opinion that, and I'm not alone in this, that in the years to come, we will see a movement away from the cookie cutter treatments that are based on imperfect disease risk assignments and moving towards a personalized approach that accounts for disease biology, patient-specific factors, and also is dynamic, meaning how patients do during the course of therapy. Lastly, we will discuss some of these approaches that are either already being done, require some improvement, and of course, hopefully may be available in the future. First off, what do we mean when we say personalized or precision or individualized medicine? These terms are, often regarded as being synonymous. They're really not, and we won't get too into the weeds about that. But essentially, when we're talking about precision medicine, it accounts for the things that I just described, and that is MDS, because every case of MDS in a marrow is different, and literally everybody is different. So no two patients with MDS are identical. Precision medicine or personalized approach accomplishes the goals of that specific patient. Maybe we have to go a bit more basic, and I don't want to belabor some of the things that might have been already discussed at some of the previous webinars, but what is MDS? This is an illustration on the bottom that describes what a normal hematopoietic compartment is doing. You have young stem cells that have varying roles, with many eventually receiving instruction to make essentially children's cells that are still relatively immature, but eventually grow up and form one of several types of blood cells. MDS is a disease in which these earlier cells go down the wrong path as a result of many factors, many of which interplay and accumulate within the bone marrow. These are genetic and what we call epigenetic alterations, but also increasing evidence suggests that many factors outside of these cells themselves contribute, such as the bone marrow microenvironment and the immune system. A common question patients ask me is, quote, how long have I had this, end quote. There's no definitive answer that can really be applied, let alone to all patients, but this can be months to years to sometimes decades, we believe. So going back to our objectives, and we have to review this disease biology. Getting to what makes this biology of these diseases different and how this translates to the opportunity for precision medicine, or colloquially personalized medicine. As you can see here in this graph, representing the types of chromosomal abnormalities detected in MDS cells, about half will have no detectable abnormalities. I will say that this is using conventional techniques. There are some studies to suggest that with more precise or deeper techniques, about 30% of cases of MDS with a quote unquote normal karyotype, or essentially normal chromosomes, will in fact have a detectable abnormality. Aside from this, using standard techniques, you can see that there are a few that are recurrently detected. In fact, where is it? In the middle here, deletion 5q, monosomy 5, or essentially loss of one of the chromosome 5s. Deletion 7q and monosomy 7 are loss of one of the chromosome 7s in its entirety. These are inherently diagnostic of MDS when paired with low blood counts. Many cases of MDS will have more than one chromosomal abnormality. You can see at the top here. Some will have actually what we call complex karyotype, in which there are 3 or more of these chromosomal abnormalities, essentially large segments of DNA that are wrapped into these larger structures that are either lost, duplicated, or in some cases added. In addition to the relatively larger segments of DNA that we just talked about that are otherwise disturbed in these MDS cells by way of chromosomal changes, there are also more discrete mutations that are identified when evaluating the DNA inside these cells. The vast majority of MDS will harbor at least one mutation, and more often than not, more than one. Sometimes, upwards of half a dozen to sometimes more. The most common types of mutations are that in genes responsible for, you can see in the top left, RNA splicing, but mutations in genes responsible for what we call epigenetic regulation are also quite common. There are hundreds of genes that can be detected in MDS and felt to play some role in disease, and there are thousands of types of mutations that can be detected in these genes across many cases of MDS. Each potentially doing something a little bit different. The vast majority of these diseases will be what we call acquired. That is to say, for one reason or another, the mutation occurs after a patient has inherited their specific genetic signature from 2 parents. However, in being thorough, there are some select cases in which the disease is felt to arise out of an inherited fashion. Many of these syndromes have been recognized and are currently being studied, typically with at least one family member affected. As you might guess, it gets even a bit more complicated. An MDS cell acquiring mutation is just not enough. An MDS cell typically requires more than one hit, if you will, to its genetic machinery to put the cell on the path to disease, being MDS. There are different combinations that are possible. And in fact, one could argue, and I won't say infinite, but inordinate number of possible combinations that relate to the genes affected, the specific mutation types, the sequence of acquisition, and to a certain extent, the timing of acquisition. Some of these earliest hits, as we're going to call them, that can be identified using elegant techniques are the spliceosome mutations that I showed you a couple slides ago in the top left corner of that pie chart. And then after that, some of the mutations can be in these epigenetic regulators. These types of mutations are thought to make it easier for later mutations down the line here, you can see, to be acquired. And these tend to be the later ones that tend to really, as best we can understand it, impact prognosis, which we will talk about a little bit later. We should acknowledge that particular lesions, whether it's a chromosomal abnormality or a mutation, are not purely diagnostic of MDS. We know that these lesions can be found in, quote unquote, as it stands right now, normal bone marrows in the person perhaps sitting right next to you, if you're sitting next to somebody. This increases with age. It is only after a problem ascribed to this lesion arises that we say a person has a particular disease on the spectrum that you can see here on the left. We don't have to get into the details about what these specific entities are, but suffice it to say, you need more than just a clonal abnormality in a chromosomal change or a mutation. So, I mean, we don't have to harken back to the first slide, but essentially, you can see that there's a lot of what we call heterogeneity in how these cells can sort of divide, create more of themselves. And there's essentially a fairly unique signature to each case of MDS. I mean, this figure on the right here further illustrates how this variation can be encountered between patient to patient. Before the MDS has progressed to AML, you can see a few different, we'll call them, types of cells, different fingerprints, if you will, among this collection of cells, some of which are associated with the disease. However, we reach a crossroads, one inherent to the topic at hand, and every MDS and every patient is different. Then if every patient with MDS is different, and thus every case of MDS is different, then how can we study this as a whole? This is an ongoing issue in clinical trials for which we have to account, and striking the balance between this and having just enough similarity between disease subtypes to allow enough people to be studied in the same fashion to A, see if a drug works, B, see how well it works, and C, if we can, compare it to other drugs. So we do have subcategories of disease as per the WHO or the World Health Organization, which is, I'd say, the main entity that's currently responsible for defining these diseases and subtypes among them. These subtypes vary by you can see here, these are some of the basic sort of determinants, their histologic features, the number of blasts, marrowblasts, or other cells known as ring sideroblasts, and in some particular cases, chromosomal abnormalities that are identified. Up until now, as this is being conducted with the help of the MDS Foundation, I've mostly talked about MDS, which is an early disruption of these cells before they grow up, and many of these cell types that are propagated can carry this disease machinery by way of the chromosomal stuff, the mutations we talked about, namely the ones that have DNA in the blood, which are the white cells, and how we detect these genetic disturbances. But what makes AML, quote unquote, different is that this disruption is paired with what we call a maturation arrest, in which some other lesion in the genetic material, another quote unquote hit, does not really allow the cell to progress to the next stage of maturation or growing up, if you will. When arrested, of course, that means less white blood cells can be made, but also you get a backlog of the precursors that we call blasts, and an increase to blast percentage that's 20% or more inherently defines AML in this case, which can create newer problems. Suffice it to say, MDS and AML are two currently separated diseases based on blast counts, but their biology is virtually similar and can be regarded as diseases on the same spectrum. My mentor used to call AML, and probably still does, a quote, very, very, very bad version of MDS, end quote. And conversely, some providers call some forms of MDS a pre-leukemia. The latter can be debated in many cases, but the logic is fairly sound. So you can see the pie chart here describing the chromosomal abnormalities and mutations that are currently identified in AML. This looks very similar to MDS, right? Many of the same spliceosome, epigenetic, regulator mutations are identified. This is because about upwards of half, like 40 to 50% of AML will arise out of MDS, either because of some of the findings in the bone marrow or because some person was known to have MDS and then unfortunately had their disease progress to AML. Some abnormalities, namely from a mutational standpoint, are a bit more specific to AML, but not 100%, but a bit more specific, such as mutations in NPM1, in FLT3, actually the most common mutations in AML. There's a similar distribution of IDH1, IDH2 mutations, and as well generally the same rate of what we call TP53 mutations. But this is really just illustrating that there is still this wide diversity in the lesions or hits that constitute any one diagnosis of AML, and it's, suffice to say, pretty similar to that in MDS. So that was a simplified but hopefully informative overview of the cytogenetic or the chromosomal and molecular or mutational signatures that can be associated with MDS and, for that matter, AML. We could spend a whole lecture in taking it further to gene expression, proteomic and RNA studies, a lot of complicated things to really dig down to the root of what makes every case of MDS and AML truly different from patient to patient. But hopefully you now understand that why the quote unquote standard treatment may not be applicable to all patients. In reality, it is the appropriate choice. Hey, it's called a standard for a reason, but we can and we will discuss this further. As a provider, we have to help our patients, right? Or at least try to. So in formulating a treatment plan, we need to get a sense of how this disease is likely to behave inherently. And of course, down the road with certain treatment that may or may not be offered to a particular patient. Some chromosomal abnormalities, this is getting to AML, are found to impart prognostic significance. This is AML again. I find this to be a misnomer, but there are some lesions that are associated with quote unquote favorable risk, AML on the top row here. And then on the other hand, others that predict a disease which is likely to be more stubborn to our frontline therapies and or more likely to relapse after an initial good response. If disease doesn't harbor either lesions in the top row or the bottom row, then it's assigned sort of the quote in the middle basket here. It will be called intermediate risk disease. This is only looking at the chromosomal changes, but this is a visual representation of what we mean. You can see why we call it adverse risk, unfortunately, perhaps also why I dislike the term favorable risk, AML, in which only about half of patients will be cured. And this is, I'd say this data is 20 years old, but the curves and the expectations are largely about the same these days. That's just the chromosomal stuff. So accounting for the other half of lesions in those pie charts, the molecular data or mutations that we can identify. We know that some mutations are prognostic and in some cases with a lot of weight. The likelihood of AML stubbornness is largely guided by the interplay of two key mutations, the two most common, NPM1 and FLT3 mutations. But there are some mutations in AML that are associated with more difficult to treat disease, and these include disease harboring TP53 on the bottom here, ASXL1, and I will say to a lesser extent, quote unquote lesser extent, ASXL1 mutations. Some data suggest this is a bit more nuanced, but certainly disease harboring a TP53 mutation or RUNX1 mutation or RUNX1 mutation is more likely to be a bit more difficult to treat. Combining these two baskets of data, chromosomal and molecular lesions or hits, we can create a more refined estimate of how a patient is likely to do. I say likely because this is not set in stone, and we have, we see many patients that are the exception, both in having a more difficult and shorter disease course, and others that surprise us in a great way. This is using the ELN, or what we call the European Leukemia Net 2017 classification, which is the current tool we use to assign a disease risk in AML and inform on prognosis for a patient. And you can see it can give us a sense of how someone is likely to do based on what their disease is telling us. Baked into the cake, however, here is also, of course, the treatments that these patients, that have received as well, which we can see here over time may be translating to better outcomes by era. The higher the curve, the better the survival. And from the mid-1970s to as this study's end, which was 2016, look, almost tripling in the long-term survival, if not cure rate for these patients. This is felt to be multifactorial, related to better treatments, we think, better antibiotics, and supportive care in general, but also very likely the better availability and safety of stem cell transplant, namely allogeneic hematopoietic stem cell transplant. Which is why I don't mean to be deceptive, but this is only for patients that are aged less than 65 years at diagnosis. This, unfortunately, is how we've done when looking at patients that are aged 65 years or more at diagnosis, who tend to be less appropriate, quote unquote, or fit, whatever euphemism you like, for intensive therapy, including transplant. And thus, many of these patients will receive what we call less intensive therapy. The figure on the right illustrates the long-term survival here, 5 years, based on age of diagnosis. It's clear to see that older and intensive therapy ineligible or largely frail or unfit, again, a lot of these terms are overlapping. Some of these are different. These patients don't fare as well as their younger counterparts. This invokes the reality that disease biology, the first part of this webinar, is not the only ingredient in the soup of what makes every person with AML or MDS, for that matter, different. There are patient-specific factors for which we have to account. Older patients have a bone marrow, even if normal, is aged itself and a bit, I'd say you could say tired, to the point where it can only really handle so much stress, and the stress that's placed upon it by some types of therapies. With increasing age also comes an increasing likelihood of having other diseases, what we call comorbidities, diseases that impact sometimes pretty important organs like the heart, the kidney, the lung, the liver. How can I forget, these major organs? And this makes it a bit higher, the risk associated with some of these therapies that can themselves injure these organs, and in some cases to the point of limited and perhaps no return. Not to scare anybody, but these are the risks that have to be accepted and discussed. Lastly, as humans age, we undergo changes in fat and muscle content that influence the metabolism and distribution of particular therapies, and this can affect clearance, which can likewise affect toxicity and effectiveness. However, I need to come back to the observation that increasing age also predicts a higher chance of an individual having more stubborn disease biology. So you can see really the intricate dance of disease and patient specific factors that go into this calculation of what fingerprint of MDS exists in the patient before provider, who is a specialist. And you can see, hopefully you can see now why we in fact need specialists in these diseases. Some patients will go on to receive an allogeneic hematopoietic stem cell transplant, which is really the planned final aspect of treatment for many patients with AML and MDS that are felt to have disease that is unlikely to remain in remission with their frontline therapy. Top left here is kind of like a graphic of what this entails. Donors receive myeloid growth factors to mobilize these stem cells, which kind of migrate into the blood. They're collected by a process known as leukapheresis. The recipients, basically the patient, receives chemotherapy and in some cases radiotherapy, which is designed to really prevent what we call the graft, the stem cells, from being rejected. It also reduces the number of tumor cells when these stem cells are in fact really transfused. This allows for these cells to kind of create niches for their what we call engraftment. This is a process which basically keeps a patient in the hospital for, anywhere from, 14, 20 days, and in some cases a bit longer. When these conditioning regimens are of higher intensity, they can be quite toxic. We do have lesser intensity conditioning regimens that allow many more patients to proceed to at least some form of allogeneic hematopoietic stem cell transplant. You can see on the bottom left here where the number of matched unrelated donors, matched unrelated donor transplants and haplo, what we call haplo or half match transplants is increasing. I think this is why I'm not alone in this hypothesis. We think this is why maybe some of the outcomes for these patients over time is improving. More patients can get to transplant. However, most patients will have to accept a 20%-ish. There's clearly some variance, but a 20% risk of dying from transplant itself. This is higher for older patients or those with particular medical issues. You can see on the right here that among patients that unfortunately pass, after transplant, anywhere from 1/3 to 1/2 of patients will die because of disease coming back and causing problems, but the rest will die of some form of organ failure, infection, and graft versus host disease. So this is a procedure that, even though it's going to be prioritized for some patients based on their biological factors of the disease and also patient-specific factors, is nothing to sneeze at. It is something that is clearly effective, but for some patients, it is not a meaningful part of the individualized patient plan. We've talked about how we can separate and individualize the treatment of patients with AML using the cytogenetic molecular features that factor into, ELN 2017. But what about MDS? Not every patient with MDS will need a transplant. Some patients will have predicted what we call lower risk disease and sometimes be observed as best we can estimate. We have several tools available to us to really individualize the treatment approach. Here's what we call the IPSS, or the International Prognostic Scoring System. This takes into account several variables like the types and depths of cytopenias, what we call, the low blood counts, the number of bone marrow blasts, and some of the chromosomal abnormalities that can inform prognosis. This essentially spits out a number that we can transpose to a specific risk group, which itself is associated with an estimate of how long this disease is likely to remain relatively quiet, and associate with what we call median survival. Median meaning half of people, in that kind of risk category will live longer. Others will live on the shorter end of that estimate. So the IPSS was revised in 2012 to be a bit more specific in these factors, using more of the chromosomal data and really parsing out the number of bone marrow blasts and cytopenias. So we get, we think, a bit more specific for each patient before us. And this is the calculator that many of us use every day, that, like the original IPSS, accounts for all the data we discussed thus far and can give us a sense. A sense meaning because it's an imperfect one, unfortunately, of how a patient's disease is likely to behave. Based on that estimated behavior, we put disease into one of two baskets: lower or higher risk disease, as this is the distinction that has been made between a disease that requires consideration for the transplant we talked about, the only curative therapy for MDS as it stands right now, or not, or no transplant, either observation or addressing some of the other things that align with the goals relevant to the patient with that particular subcategory of disease. These goals are individualized based on disease risk, what we talked about, what is possible with regards to therapy tolerance, should it, in fact, be high risk disease. But of course, what the patient wants, what quality of life aligns with his or her goals. For lower risk disease, we can sometimes just watch if the blood counts aren't that low, or if there are no really disease-related problems. Sometimes there are some symptoms that are related to blood counts. So why rock the boat? Just watch with frequent blood counts, and we can, if something crops up, we address it at that point in time. Some patients, even with low risk disease, do have low blood counts that require consideration for some type of therapy that can perhaps improve it. So not really addressing the disease itself, but addressing some of the problems that come with the disease. This is typically anemia, and we have some medications that can improve this problem, but this differs between patients based on a number of factors. Higher risk disease, as I mentioned, our goal is to actually put pressure on the disease itself and not just address the problems that it causes. High risk disease must be really met at the front lines, as if we are accepting, we have to essentially put pressure on it so it would hopefully stall its progression to AML. And if you're treating it, hopefully, putting the patient through a more intensive, process known as transplant to hopefully abrogate that or get rid of that risk altogether. But wait, you might notice that we just spent 15 minutes talking about mutations in molecular data in the first kind of portion of this webinar, and how is this, how this contributes to the signature. But the IPSS and the revised version that, is kind of assigning disease risk doesn't account for any of that information. How precise or personalized can it be then? Unfortunately, you are right. We do know that some mutations in MDS do carry prognostic weight, including the ones on the right here. But much of this data has come really after the revised IPSS was released and, kind of was taken up and has really become the standard. I would argue is the standard. This is one of the first great studies on the right here. So a total of really 51% of all patients had at least one mutation, including half of patients with autosomal karyotype, and looking at the independent impact of these mutations. They did find that they themselves each have some prognostic weight. The ones here: TP53, EZH2, ETV6, RUNX1, ASXL1. These are all unfortunate predictors of poor survival in patients with MDS, independently of the other established risk factors that we talked about. There has, this is not to say that there hasn't been attention to this. There has been a longstanding effort since this time to really create a tool that incorporates this mutational data to make our prognostication even more accurate, and we can really dial down to good estimates that we can give the individual patients before us and put together a precise plan, precision medicine, to tell us what we can expect with the disease course. Are we best served with early transplant in this particular case? Fortunately, we may be making some headway. Just this past December, we got a first look at the revised version of this prognostic scoring system that does in fact account for the mutational data. It's burdensome, but it does appear to perform quite well. You can see here on the right that approximately, in the red circle here, approximately 30% of patients, although previously considered to be among patients in the lower risk category using the IPSS-R, you can see on the left here, the far left, actually when you incorporate the molecular mutational data, are now inherently defined as being higher risk disease, kind of what we suspected all along, but now we actually have a good tool that accounts for that. This essentially changed the game entirely with regards to what the provider is going to be recommending. And most of us think this is for the better. This probably will take some time to really, say, get used to, but also and maybe be kind of validated in future studies as well, including those that incorporate transplantation. So we have reviewed the extraordinary biologic diversity that exists among patients with MDS and AML, and how this lends weight to the notion that standard therapy may soon be, I would argue, an antiquated term. But let's talk about some of this in the context of maybe something we could say is positive. One of the first examples that I would consider to be precision medicine. This would be the use of a medication known as lenalidomide, the brand name being Revlimid, for the treatment of lower risk MDS that harbors a particular chromosomal abnormality known as deletion 5q. This is associated with sort of a textbook or classic presentation known as the 5q minus syndrome, which tends to affect females with an anemia predominance and sometimes a high platelet count, actually. Lenalidomide and its mechanism of action were actually not really understood until, I would say, quite recently, and it appears to exert really several effects on malignant hematopoiesis, basically the MDS cells. But for this particular patient with low risk deletion 5q MDS, lenalidomide appears to be associated with an exquisitely high rate of response by way of making patients that are requiring red cell transfusions no longer require these, and what we call becoming red cell transfusion independent. Many patients do, in fact, appear to achieve a form of complete remission. We can parse out whether this is clinically beneficial. We still use this medication today and rely upon it for many patients that appear to fit this particular subtype of disease. These are mostly relevant to patients with low risk MDS, for which the goal is traditionally to prioritize the reduction in need of transfusions or other MDS-related problems like infection or bleeding, as well as quality of life improvements, we think, as well. A more recent example is the use of a medication known as Phattercept, which is regarded as being what we call a TGF-beta ligand trap. This was just approved in 2020, and this medication, similar to lenalidomide, appears to be particularly effective in a subgroup of MDS, kind of further supporting this precision medicine initiative. One of the subtypes we call MDS with ring sideroblasts, which are a particular form of red cell precursors that can be increased in some forms of MDS, particularly the lower risk forms. Because of this initial observation, this medication was studied in only these patients in a subsequent study. As you can see here on the right, up to 40% of patients eventually end up not needing repeated red cell transfusions. These patients became red cell transfusion independent for at least 8 weeks. However, this is not a game changer. As you can see here, that over time, the rate of remaining transfusion independent does decrease over time. But this is, I think, still an informative example of a particular medication with a, one, novel mechanism of action, and two, being used in a particular subgroup of MDS. We should also note that the last two things we discussed, being Revlimid or lenalidomide, and this drug, Phattercept, are approved for lower risk disease only. For higher risk disease, the backbone of treatment, and many of you might know this, has been what we call the hypomethylating agents, with the classic ones being azacitidine and decitabine. The mechanism or mode of action of what we call the HMAs, hypomethylating agents, has not really been completely understood, surprisingly, but is thought to involve both kind of classical cytoreductive or chemo-like effects, but also a so-called epigenetic effect, or the other ways of modulating or influencing hematopoiesis towards the favorable. Responses, are observed in roughly about 40 to 50% of patients, including the classical complete remission rates as seen in AML with conventional chemotherapy, but also some less than complete remission responses. Maybe just not getting that as good of a degree of count recovery, or maybe there isn't count recovery beyond the red cells and the patient is achieving transfusion independence, still beneficial for many patients. Both of these agents, being azacitidine and decitabine, were approved in the early to mid 2000s, both of them based on randomized trials, which did support some benefit in patients with higher risk disease. This is MDS, as shown here on the right. Unfortunately, complete and partial responses, it's only about 20% of patients. And among those who do respond, the median or you could say almost the average. That's not the true definition of median, but the median duration of responses remains well under 2 years. After a failure of these drugs, after these drugs fail our patients, we're really in a different place with a median survival that essentially approaches anywhere from 6 to 9, maybe 10 months. There are a lot of studies ongoing in the past and ongoing that have really shown what these HMAs are doing, and if there's a way we can sort of leverage them to kind of improve upon them. So this is really an important observation, highlighting, that, the multitude of effects that these drugs have might lend weight to subsequent efforts to either add drugs to them or use them in different ways. So this might seem like more of a disconnect, but it's important to note that there's a classical induction regimen for AML, which was originally formulated in the early 1970s, but it took a lot more time to develop other medications that either improved upon this, kind of piggybacking the whole HMA discussion, or alternatives for the patient who is otherwise not a reasonable candidate to receive an intensive therapy were developed. It really took half a century to really get to understand the benefit of combination therapy in limited circumstances, whether the addition of gemcitabine ozogamicin for some types of AMLs or FLT3 inhibitors like midostaurin, but also, to have less intensive therapy from patients that can still derive benefit, albeit maybe not a whole lot. As we talked about, azacitidine and decitabine for MDS were available since 2004, 2006, respectively. About 10 years later for AML, the targeted therapies, namely, we talked about one, gemcitabine ozogamicin, or the IDH inhibitors and some of the FLT3 inhibitors and the venetoclax-based combinations. You can see that the last 5 years or so have really been a golden age of AML approvals. Whereas for MDS, there's been a stagnation with the approvals in the early 2000s that we've talked about already. And then only in 2020 with Phattercept that we talked about, has modest benefit in a particular subgroup of MDS. And then we have, we didn't talk about this, but an oral formulation of decitabine, which is definitely a nice tool to have. It's perhaps a bit more convenient, but by no means is a substantial improvement or, a quantum leap forward, and certainly not one in the effort for precision medicine. So what we've done in an effort to potentially individualize treatment decisions is to identify particular subgroups within the larger MDS population that may be inherently more responsive to what we have available to us, like an HMA, like azacitidine or decitabine. We do know that patients with MDS harboring a specific mutation known as TET2 have a higher rate of response than HMA. But unfortunately, as you can see on the right here, the outcomes appear to be not that much different. Other attempts to really uncover the reasons underlying resistance, or for that matter, response to HMAs, have shown that patients destined to respond have certain features. One of them being that, they're more likely to have, among responding patients, they're more likely to have these progenitor stem cells, which are the disease cells in this case, that are in the cell cycle. This makes sense because, the mechanism of action of these agents in the HMAs, which essentially require their incorporation into DNA that is being replicated, which is a chief feature of cells that are cycling. These researchers also found that response to an HMA, in this case it was azacitidine, was associated with a certain sort of signature in gene expression, and one that was enriched for basically an increase in inflammatory response. There was also a significant increase in enrichment for pathways related to cell cycle regulation, and some, you can see here DNA damage response pathways, among a few others. However, this is informative clinical research, but it's certainly not something that's going to be a widespread technique, at least not in the near future. So this can't be done for every patient by any stretch, but clearly shows that if we look hard and deep enough, we can find ways to predict response in a hopefully precise way for the individual patient with particular therapies. In this case, our quote unquote standard HMAs. But what if we want more? HMAs are great, because they are effective, but certainly not for all patients. And even among patients for whom they are effective, the effect is often not long lasting. Many of these trials of the last nearly 2 decades for patients with MDS and the patients with AML that really couldn't get intensive therapy, have centered around adding drugs on top of an HMA, backbone, if you will. And one of the greatest breakthroughs in the last few years has been the development and study of a medication known as venetoclax, which is what we call a BCL2 inhibitor, and essentially increases the response that would otherwise be expected with an HMA alone. This has also been studied in a randomized phase 3 trial. It doesn't really get much better than that in patients with AML that were felt to be, quote unquote, unfit for intensive therapy. And there was also a survival benefit that appeared to be independent, however, of any particular molecular subgroup, which you can see here on the right, if you know how to interpret this kind of this graph, looking at patients' disease outcomes by their presence of a particular mutation, FLT3, TP53, or NPM1 mutation. No difference in therapies, but still, suffice it to say on the right here, a hazard ratio which does support a benefit. IDH1 and IDH2 mutated disease might be the exception. In other words, this might be the particular subgroup of disease that may respond a bit more robustly. This was an AML trial, but I just told you that AML and MDS are very, very similar diseases. And if we can't break the deadlock with identifying particular subgroups of disease that respond more explicitly with our standard HMA and MDS, well, then can't we just borrow some of these treatments that appear to be working in AML and use them in MDS? So this, in fact, is being studied. And we have data that the addition of venetoclax, that drug that, I was just talking about, to standard HMA therapy, which in this case is AZA, does appear to have a higher rate of complete remission that you would otherwise expect when compared with, azacitidine alone, and also some responses that, even though are not complete remission, might still be beneficial for the patient, namely who's trying to get the transplant, just needs a little push of therapy to, bring blasts down, hopefully clear blasts so they can proceed to transplant. Phase 3 studies comparing azacitidine plus venetoclax versus azacitidine alone, much like that trial in AML, but in higher risk MDS, are ongoing, and they are in fact accruing well, and we await the results to really, I'd say, definitively address whether the addition of venetoclax is beneficial for patients with higher risk MDS, as it has been shown to be for AML. So unifying the first part of the talk with how MDS and AML is comprised by a molecular standpoint, but also how we can leverage this information to study and have available effective therapies that target these lesions, we arrive at this table, I would say, which is simplified, but hopefully gets the point across. We have FLT3 inhibitors for the treatment of FLT3 mutated AML, but these are, I'd say, not as much of a significant option for the patient with MDS, with which there's a lesser association, with these mutations. However, we find a similar rate of IDH1 and IDH2 mutations in MDS and AML, and this might serve as another key example of how precision medicine can be borrowed from the AML world to help patients in the MDS world. The IDH1 protein, that is essentially produced by the IDH1 mutation in MDS cells, not to get into the weeds, but essentially allows for the production of a toxic metabolite that can eventually stall some of the critical machinery that makes MDS and AML cells go. The IDH1 inhibitor, which is an oral pill known as ivosidenib, was initially studied in AML. It's a targeted treatment, inhibits IDH1, and thus essentially stops the production of this toxic oncometabolite, and can hopefully reverse some of the dysfunction. In fact, it does. In this study, these are mostly older patients. In fact, most patients were older than age 75 years, and actually half had already received an HMA, relevant because of what we just talked about and what this deadlock is we're experiencing. About 40% of patients, that were red cell transfusion dependent became independent. So that's quite meaningful. And you can see here on the left that the rate of what we call complete remission was 30%, and upwards of 40% in patients without prior exposure or receipt of an HMA. But you do get some less than CR responses, so maybe about a 40 to 50% response rate. And many of these responders on the right here, you can see, had ongoing response at 2 years of follow-up, but the median overall survival was about 1 year. So some patients on the right here are doing quite well. Furthermore, there was a recent phase 3 randomized trial, again, doesn't really get much better, that showed when compared with azacitidine alone, this is in AML patients, the addition of ivosidenib, which is the same IDH1 inhibitor, led to higher rates of complete remission. It was essentially triple, basically, and higher rates of composite remission, including some of those less than CR responses that we briefly talked about. these increased rates of remission did in fact appear to translate into better outcomes. You can see here that the overall survival of patients treated with azacitidine alone was about 8 months on the average. And that's generally what we expect for patients. These are AML patients, again, treated with azacitidine alone. So this is actually what you would expect. However, when ivosidenib was added, the median overall survival was tripled to be 2 years. This was in mostly older population of patients and a population of patients, I would say, which was quite similar to that studied on the randomized trial for the addition of venetoclax to azacitidine, which was that first borrowed AML therapy we had discussed. So it remains to be seen which combination is in fact better for the patient with this specific subtype known as IDH1 mutated AML. Nonetheless, this is still a welcome option, but the treatment of patients that up until very recently, had limited to no options. So given these encouraging data in AML, this combination is also being studied in patients with high-risk MDS. Some initial data were presented at our annual hematology meeting this past December, and the rate of complete remission was 46%, which is really, I'd say, outstanding when compared with that expected with azacitidine alone. However, you can see here on the right that the median duration of response was still just over a half a year, and many of these patients are still not living for more than a year, so still some work to be done. Just like IDH1 mutations, targeted therapy against IDH2 proteins that are dysfunctional due to mutation are also being studied in MDS. IDH2 mutations are found in about 5 to, I'd say, at most 10% of patients with MDS. Anacidnib or enasidenib, this is the oral IDH2 inhibitor, which leads to, I would say, decent responses in patients with IDH2 mutated relapsed or refractory AML. This pill has been recently studied in MDS as well. And this is, the MDS data that I'm presenting to you. So an overall response was achieved in about 53% of patients with a median duration of response of 9 months. Half of these patients, had prior HMA treatment, and half of the patients that actually had prior HMA treatment also responded. The median overall survival was about 17 months, so not too bad for a daily pill, which has also been studied in combination with azacitidine, just like ivosidenib, the IDH1 mutation, the IDH1 inhibitor, pardon me. And data were presented at another meeting this past summer, and this combination, so anacidinib with azacitidine, demonstrated a 20% rate of complete remission. So not terribly high, but when you include some of the lesser than CR responses, it was about 80% plus, which is better than patients treated with the pill. So encouraging, but we definitely need longer follow-up to see how these patients are doing down the road. Perhaps one of the more critical deficiencies in the precision medicine initiative is how we can serve the patient that has disease harboring a mutation known as TP53, which, as we discussed before, is associated with more difficult disease biology, and itself, in many cases, renders a case of MDS as being higher risk outside of anything else that the disease is associated with. There have been attempts at developing medications that, quote unquote, target the protein that is created when this gene is mutated in the disease cells. This compound here, known as APR-246, now known as epernetaprop, was originally hypothesized to exert this exact effect. In fact, it was thought to really refold the mutant protein and reactivate it so it can do the job that it was otherwise used to doing, a pretty critical one, mind you. However, we now suspect that this might not be the true mechanism of action, but nonetheless, it still appears to be an effective medication in this particular subgroup of disease. When combined with azacitidine, which is the HMA, in patients with TP53 mutated AML or MDS, it was two together here, which I think is a good thing. The rate of complete remission appears to be 40 to 50%, and a median overall survival basically about a year, which is, sorry to say, outstanding when compared with what we had previously. Other attempts, and I would say probably the ones that have a bit more promise, are those identifying therapies to which therapies that are really geared towards inhibiting what we call the CD47 or SIRP alpha axis, which essentially, when inhibited, appears to restore the body's innate immune system to seek out and clear these tumor cells from the marrow and blood. Some initial studies have shown that when combined with azacitidine, the rates of complete remission are about 45% and an overall response rate that is approaching 70 to 75%, which rivals anything available to us at the moment. Because of this high response rate, you can see here that on the right, the survival for these patients appears to exceed a year, which, just like the last slide and the last kind of curve I showed you, I'm sad to say it is quite impressive. This is a busy slide, but is intended to demonstrate that with this realization, we think we can kind of build upon this precision medicine initiative and sort of add some of these novel agents together. And these are some preclinical data to suggest that we can add these agents. The one before was magrolimab, which was an anti-CD47 treatment, not only with azacitidine, but also the venetoclax, this kind of newer therapy that I told you about. And in fact, these preclinical studies, and some are test tubes, but others in mice, has clearly some good effect, which lends some confidence that the medication might have an effect in humans. And sure enough, this triple combination appears to be quite effective for patients with this particular molecular subgroup of MDS, which is among the most stubborn we have and face. This update that was presented at the same annual hematology meeting this past December shows that more than 70% of patients have response, including a good depth of response. What is yet to be seen is how long these patients respond, and if this is long enough and deep enough to get patients to transplant, which we still think provides some benefit for these patients. We still need to parse out, what depth of response is meaningful, and which patients, and in which patients further lending support to the venture for precision medicine, for sure. In parallel, there's also some interest in a theory that we can alter some of the disease biology that is predicted by the presence of a spliceosome mutation. As harkening back to some of the earlier slides, some of the earliest mutations we identify in MDS that allow MDS to really kind of come to light. This is elucidating a pathway that involves what we call the interleukin-1 receptor associated kinase 4, IRQIV4, which plays an essential role in really the inflammatory and other pathways that promote disease. There's this oncogenic isoform of this protein known as the long form, which is frequently driven by spliceosome mutations, and I would say is preferentially expressed in at least half of cases of AML and MDS. So this appears to also be and this also appears to be a driver of some resistance to the other therapies we have in our toolkit. So this is a compound that inhibits this specific protein. And although this study is ongoing, definitely offers some promise that this could be a reasonable target to investigate and develop newer and likely better therapies leveraging it. So this is intended to be a busy slide, not to overwhelm you, but just to illustrate that it's difficult to just pick and choose a couple of the examples of how we are slowly, I think, kind of breaking down the umbrella term MDS into smaller and smaller subcompartments that are driven by disease biology and also, to some extent, patient-specific factors, and inching closer towards a precision medicine approach. This slide is only meant to convey that there are many, many, many targets that are associated with the disease or potentially targetable, and in some cases have some, other investigational agents that are already being studied or may soon enter the clinical trial space and hopefully provide quite soon some benefit for our patients. So, what do we need to do? The definition of quote unquote successful treatment in the modern era needs some updating. This can take several directions. First, we need to continue to elucidate the mechanisms of disease initiation, what puts the disease on the path to become disease, and then what allows it to persist and kind of overtake the bone marrow. That will, this study will, likewise lend clues as to which targets in the disease cells are worthwhile to approach and try to address. This will foster the development of new therapies, which may break down the barrier separating intensive versus less intensive eligible patients, therapy eligible patients. Less intensive therapies, must be evaluated, preferably against standard of care comparators, in larger analyses that account for, pretty much all the subgroups that can serve as surrogates for individual patient differences. It's my hope that many of these future trials will include both patients with AML and MDS, in particular molecular subgroups. And just, given the nature of the patient population affected, we have to study patients that align with what we see in real world practice. So, these are not always young marathon runners, unfortunately. These trials should include, quote unquote, older patients with more, liberal inclusion criteria, knowing that some of these patients are going to have, heart, lung, kidney, liver disease. So we kind of have to jump those hurdles as well. In turn, this will hopefully improve the outcomes of patients. That's what we're trying to do, right? The ideal therapy is, of course, one that only affects disease cells and leaves normal cells alone. So we don't run into the low blood count issues that we that we run into with, many therapies we currently use, unfortunately. But this is, quite aspirational, certainly in the case of MDS, given, like I just showed you, given its wide array of biological differences on a patient by patient basis. And this is, which makes the prospect for precision, or to a lesser extent, individualized medicine, I would argue, and hopefully you believe me by now, quite a valuable one. So with that, I'd like to thank you so much for the honor of being able to speak, to you and soon with you. Hopefully I've grabbed your attention, and I look forward to any questions you might have. Thanks again.
Thank you, Dr. Shallis, for your wonderful presentation. Thank you all for joining us today. My name is Janice Butchko. I will be moderating the Q&A for Audrey Hassan today. If you haven't already done so, please submit your questions through the Q&A button on the bottom menu bar. For those of you who would like to revisit this recorded webinar, a viewing link will be sent to all registrants and posted to the MDS website within 10 business days. So we're going to start our first Q&A. Does anybody have any questions for Dr. Shallis they would like to start? Okay, our first question is from Debbie. Eopitin alpha, how to combat the shortage that my oncologist says exists?
Sure. Hi, Debbie. Yeah, I would say that probably is more of a larger question outside of precision medicine, but there are alternatives, just to kind of let you know, and I'm sure your provider knows this, that, eopitin alpha is one agent in a class of agents that, we have available to us. So I would definitely ask your provider to really be mindful of that. And we're usually pretty successful in advocating for, our patients, in the context of a shortage, especially if it's providing some good benefit.
Okay, do we have any other questions for Dr. Shallis? Okay, one from Linda. Can genomic testing predict ahead of therapy which protocol might or might not work? My husband feels like a chemistry experiment.
Hi, Linda. You're not alone in that feeling, and certainly your husband isn't either. Yeah, I mean, to be honest, that was, I'd say, really sort of the larger aspiration of this talk, and that maybe some of these fancier baseline testing methods can give us a sense of which treatments are likely to work. We think we're doing an okay job, and I'm sure by now, after listening and watching, that we still have a lot of work to do. There are some what we call cytogenetic or chromosomal or molecular slash mutational abnormalities in the MDS cells, which we do know can predict response to some therapies, and these just are inherent to what we call targeted therapies, like the IDH1 or IDH2 inhibitors, and in some cases FLT3 inhibitors as well. So the answer is, I would bet my bottom dollar the answer is yes. That it will be still imperfect, but we will be successively better as time goes on, and that just comes down to I'd say good research from good researchers, and of course support from people that are really letting us do this research. So the answer is yes, but it'll be a stronger yes in years to come.
Thank you, Dr. Shallis. Our next question is from Joseph. What are the environmental sources of benzene which can cause MDS?
Wow, that's a specific question, but certainly a very relevant one. We do know that benzene, which is, I would argue, a fairly ubiquitous molecule that's common all around us to at least some degree. So I think the question was with regards to environmental causes. It's a natural product. So it's unfortunately all around us, but there are some other exposures that have been invoked, whether it's there's sort of, solvents and other chemicals. The list is lengthy that have been sort of hypothesized to really, contain benzene, and some proven. But the list gets a little bit shorter with those that have, I'd say, pretty definitively been associated with the development or an increased risk of developing AML or MDS. I would actually point you to the website of the American Cancer Society. They do have a pretty good list of some of the agents or substances that are known to have benzene and might kind of increase that risk.
Okay, thank you. The next question is, there are many MDS hospitals and doctors. Are all or many of them doing this type of predictive research like you?
I'll be the first to say, it's a team effort. There's always more than one person kind of behind the scenes, even though one person's name is either on the research. It's usually many, many, many. So yes, you're right. There are many hospitals available. It depends on which part of the country you're in. Maybe if you're in the Northeast or, on the West Coast, maybe you have a bit more from which to choose. But suffice it to say, there are great institutions throughout this country. And it is, I'd say, a relatively small community of us that specialize in the treatment of MDS and AML. But it is a unified effort. All of us are looking for any way possible to improve the outcomes of our patients, whether it's inch by inch, but all these inches do kind of add up. So all of us, no, not all of us are doing that specific aspect of the research, predicting response to, either available or future therapies. Other providers do have other kind of focuses within that disease space. But for the most part, everyone that I would say considers him or herself a MDS specialist, is certainly considering these things for sure.
Thank you, Dr. Shallis. Our next question is from Lawrence. Are there any studies for treatments for genetic mutations for BCOR, STAG2, DNMT3A?
Good question. And this, I think, is one of the deficiencies that exists at present. I mean, the mutations that were just listed there are among, some of the most common ones we find in MDS cells. That's not meant to say that these are actually driving the disease. These are mutations that might have just been picked up along the way, before the MDS, or really after the MDS was sort of already on its path. But in an attempt to answer your question, I'm unaware of any specific agents that are certainly not available, but even in development that are really geared towards those specific mutations just for that exact reason. Maybe in 10, 50, 100 years.
Okay, thank you. What would cause a rush to transplant in a 63-year-old patient with low-risk MDS with 20q deletion only?
It's a good question. I just have to kind of, maintain some deference for the decision that was, kind of offered by the team who's caring for this person. I'm unclear as to how to define "quote unquote" rush. There are other factors that go into the decision to transplant beyond age. Our imperfect risk assignments, calling it low risk disease. But the 20q deletion, 20q is among the most common chromosomal changes that we find in MDS, and it doesn't really, I'd say, have a strong predictive. Certainly not a bad one to have, but it doesn't have a strong predictive sort of nature to it. So I suspect there were other factors that were involved, probably in the molecular kind of side of things, or things that may be kind of behind the scenes from suffice to say, there are a lot of things that, even though we call MDS low risk, factor into clinically higher risk disease. The IPSS, the IPSS-R, and the new molecular version are imperfect. So it's individualized in the true sense of the term. Everybody is different. And I suspect there were other factors. And I would hesitate to call it a rush in most cases. There are sometimes we have to rush to transplant, but MDS is usually not one of them.
Okay, thank you. Our next question is from Linda. Currently taking Vidasa shots for MDS and have recently also started Venclexta to help reduce blasts from 7%. I didn't hear anything from you regarding Venclexta?
Hi, Linda. Actually, you did. So Venclexta is the brand name for venetoclax, which is the pill that we were referencing in the slides, mostly from the AML side of things, but more recently we're encouraged that this is being studied in MDS, including in a randomized phase 3 trial that we all kind of think is going to be better than the azacitidine alone, but we still have to kind of wait for the data. The jury's still out. So without knowing the details of the case, if you were my patient, I would say that doesn't sound unreasonable. So Venclexta is venetoclax.
Okay, thank you for your answer. The next question is from KT. Does the level of blast in blood versus bone marrow have any predictive value?
It depends. So, I mean, the answer, I'd say, if I had to pick one, is yes, because there is a certain threshold above which the number of blasts actually changes the definition of the disease from MDS to AML, and that really opens up a whole new discussion about treatment options, but also the decision to transplant or not. Not every patient that has, a specific percentage of blasts in the blood or the marrow actually requires a transplant. We call an early transplant. So I would say the answer is yes. There are clear differences in most patients between how high the blasts are. In fact, that's one of the main kind of variables that's accounted for in these kind of scoring tools, which give us a certain disease risk that tell us to consider transplant kind of now or down the road. So the answer is yes.
Thank you. Anything new out there for MDS patient with declining platelets, now 30, while all other counts, red and white, staying stable? Diagnosed with multilineage dysplasia 3 years ago, ring sideroblast 15.5%, isolated trisomy 19, and pathogenic mutation in SRSF2. They're now 74 at age 74, now 77. Choose not to have transplant, prior breast cancer with radiation.
A very specific situation, but I mean, the answer is, I guess, so the question is there anything out there for this specific clinical scenario? I mean, of the things that were sort of mentioned, I would say nothing that is specific, at least based on the kind of I think there's some molecular things there, some mutations, and then some chromosomal abnormalities that were offered there. Nothing that I would say is specific for that, but that's not to say that there is no other treatment out there. Clinical trial is, always the right answer. And many clinical trials do, have a standard of care arm, and some are going to be, randomized trials. Others are going to have sort of add agent X or agent A to the standard treatment. So I would actually just kind of, and I'm sure your provider and the team is doing this, maybe ask about clinical trials if you think there's more to be done to kind of, get you some of the benefit. So, I mean, the answer is yes, things are out there. But I'd say just to kind of be humbled by the lack of, available therapies in the targeted sense for this clinical scenario. We are lacking. So reach out to your team and definitely see if there's a clinical trial that's at that center or even nearby. We do collaborate quite often.
Thank you, Dr. Shallis. Our next question is from Michelle. How far in the future do you think venetoclax will be available for people with high-risk MDS?
Well, a good question. It depends, I would say. I mean, I think we're all kind of waiting for the results, some of the final results of the ongoing randomized trial, which is really the best way to study, whether or not venetoclax actually has a benefit on top of the kind of the standard stuff, the classical things like HMAs, azacitidine being kind of the main one. We can get to the weeds about that. It's probably going to be no less than I'd say, a half a year to a year, but probably could be upwards of a couple years to actually, get through the process of approval and, of course, have it be available to us to use, even though, some of us do use that in some limited circumstances for patients with certain forms of MDS.
Thank you. The next question's from Deval. My mother was diagnosed with MDS EB2, high risk in 2019. After HMA, she is in remission. She has IDH2 mutation with IDH2 inhibitor. It's not approved for her as she does not have AML. Is there any way around this?
I hear you. I guess I would still need some more information about the details about, why would be in a sort of a kind of a rush to treat someone in this circumstance. Fine. The IDH2 mutation is noted. I think to use the word has and not had. So I presume you're telling me this is a mutation which is still at least detectable either off of blood or in the bone marrow. But if someone's in remission, I would say, well, what benefit are you really getting with adding a pill, which, it's a good pill, but it's not without side effects. So I would say you might just be exposing someone to the side effects without any clear benefit outside of a study for patients that are already in remission. So I would say, I don't know if you should be seeking a way around that.
And this is another question from Deval. She says, my mother's oncologist only uses HMA, and HMA has got her to remission. She's 67 and not fit enough for a BMT. Should we go for an MDS specialist oncologist that can provide personalized molecular care for maintenance of remission?
I hear your question. It's never a wrong answer. I don't mean to disparage anybody, but there's never not a reason to at least get a second opinion, especially from someone who is an expert in treating the disease and knowing what options are available, or if any aspects of the care can be optimized, or any other changes to kind of help the provider, but of course, help the patient, like your mom. So I would say the maintenance of remission sounds like it's being achieved with the HMA. So again, I really don't see any reason to rock the boat, not to use the same metaphor I used in the presentation, but things sound like they're going well. So I really wouldn't seek to really change anything. But I would always encourage, a second opinion. I have areas that I have expertise, and there are areas which I don't. And in the areas I don't have expertise, I usually always, I guess that's an oxymoron. I make it a point to reach out to patients, to providers that have specific sub-expertise in that area, just to kind of make sure we're doing the right thing for the patient. So I would encourage that.
Okay, thank you, Dr. Shallis. Are there any drawbacks and limitations to precision medicine in cancer?
Drawbacks, the answer is yes. I would say most of it is not probably going to reach the patient. At least I hope not. The main, I'd say, drawback is it's cost. That's the big one. But things are expensive until they become cheaper, just because people, find ways to improve them. More efficient techniques, and I'd say less waste and less, really honing in on what is meaningful for the patient. Kind of allows us to kind of rein in the cost of the research to get something operational to help patients on the back end. From a patient level perspective, it's really, I'd say, the cost, and this is where hopefully insurance carriers are really kind of sharing much of the burden. Beyond that, I'd really have to dig deep for what is really a downside. Assuming we are using precision medicine, in the quote unquote correct way, which is really going to be defined by well-designed studies, and hopefully some positive data to know in which patients it's the right thing to do. So yes, but probably not in the way I think you were intending. Who knows?
Thank you. Are there any complications from treatment?
It's a very broad question. The answer is yes. Every treatment that we give, unfortunately, the patient and the provider is accepting at least a non-zero risk of having a side effect. And it's often several, and in some cases, I'll say many cases, it's prohibitive to actually receiving a therapy. So yes, there are always drawbacks to side effects, which is why, it always has to be a, pun intended, healthy discussion with the provider about which treatment makes sense, in a particular situation for each particular patient. So a lot goes into that. And that's why, like I said, there are specialists in particular diseases.
Okay, the next question is from Lawrence. With high rate MDS diagnosed for past 15 months and on azacitidine for 15 months, blood count has not essentially changed. Do you feel that azacitidine is having an effect?
Good question. So this really kind of gets to the importance of really accounting for all the things, even the little things that, might not really be appreciated. I mean, there are aspects of treatment that, even though you might not see a change in a number, might still be providing some benefit. I would say if a patient is actually on azacitidine for 15 months with, by report, I presume high risk or higher risk MDS, that's actually pretty good. I would say it's all relative, but 15 months on a treatment and a treatment that hasn't caused any, it looks like major issues, or the disease itself hasn't become a bit more aggressive, basically, tipping into the AML basket or AML side of things. I think it's fairly clear that this is the patient who's deriving benefit from azacitidine or Vidaza. But even though, the blood counts are not perfect or not really changing, it's hard for me to say that there's really not some benefit that's being gained here, even though it's not a perfect recipe of all the benefit, great blood counts, and no side effects. There's, in most cases, sort of a gray zone. This appears to be one of these gray zone cases.
Thank you, Dr. Shallis. Are there any complementary therapies I can do while receiving treatment?
It depends on your definition of complementary treatment. That can range from aromatherapy, or art therapy to, actually having another provider that maybe has a specialty in, more of a holistic approach. Some of these, approaches do sort of butt heads against each other. And we have many patients that, really prioritize, either a relationship with someone they've had for quite some time, or a certain lifestyle that has not been disrupted by a new diagnosis of MDS. So the answer is undoubtedly yes. It just really requires a nuanced discussion about which sort of, whether it's a supplement, a nutrient, a vitamin, or anything else, which I have to say can interfere, and I've seen it many times, can interfere with treatment that would otherwise, we think, would be quite effective. But also, so not to only cheat a patient out of getting an effect of that medication, it can often promote more toxicity, more side effects that, what I'm getting at is can basically cheat you out of staying on the medication that would otherwise be given an effect. So the answer is yes, but it really should be done in concert with the provider that's prescribing, I would say, more of the heavier duty medication, whether it's an HMA or something a bit more intensive.
Okay, thank you, Dr. Shallis. The next question is from Linda. If you get blasts reduced to 0% to be ready for a bone marrow transplant, do you necessarily need the bone marrow transplant?
Good question, Linda. There's a lot that's baked into that cake. So one, ready for transplant is defined in a number of ways. And that is, a lot of it is kind of out of our control, whether someone, has some underlying, heart, lung, or other organ disease, which makes the prospect of transplant a bit more risky. But then, yes, disease-related factors, which would otherwise kind of, work into the calculation of whether this disease is going to be a problem in the near future, or we think we have time to wait. If transplant was discussed and it's kind of being, I'd say, prioritized once a patient has achieved a form of remission, which, we tend to define as having less than 5% blasts in the bone marrow. At some centers, it's less than 10% actually. Then I would say, I don't see a reason to not proceed if it's been discussed. Now, 0% does not mean zero. Unfortunately, the zero is really calculated by someone's eyes looking at a microscope and counting cells of one portion of the bone marrow at that one point in time. there is a lot below the surface. The iceberg is much more weighty below what we can see with our eyes in the microscope. 0 is looking at the very tip of the iceberg. There is likely a lot of microscopic disease for which we are not accounting, at least with that technique that, at least is being kind of used here. So I would say if the disease is otherwise higher risk and transplant was discussed and there was a plan to proceed, so as long as we get to a good response, the calculus really hasn't changed. Even though that's a good response, that's sort of the first hurdle to really get the transplant. It sounds like that's been achieved. So I would not really change that, because unfortunately, many of these diseases, are not going to remain quiet for that long. Transplant is the only curative therapy. And if that window is open, for most patients, like described in this case, I would say you have to kind of go through that window.
Great. Thank you, Dr. Shallis. The next question is, what type of follow-up will I need during and after treatment?
Depends on the treatment. There is just to kind of go back to, MDS it's different for everybody, right? I mean, the disease is different from person A to person B to person X, and different degrees of MDS aggression or being awake kind of predicts, how often a patient should be seen, whether it's, for just simple blood work or a physical exam or sitting down and just talking. How are you feeling? How are you doing? So it could be, I have some patients, and I'm not alone, that I see, maybe I see twice a year, but these are probably more the fringe cases. There are other patients that have more aggressive disease and, have disease which is just, producing more problems that we have to address, more of like on a whack-a-mole kind of timeline that I see sometimes twice a month, in some cases a bit more frequently if, we have to do some more fine tuning. So there's a wide range, and it really depends on the patient scenario.
Thank you, Dr. Shallis. The next question is there anything I can do to help manage side effects?
I would like to say yes. Up until really maybe 10 years ago, there wasn't a whole lot of, great things for nausea. Now there's, we have many medications which, help our patients get through nausea. And, in some cases it can be resolved, but at least tolerable, where they can stay on treatment, or, not have as much of a fear of, becoming nauseous or staying nauseous. Like, we have many patients that, a family member, whether it's, a parent or someone that went through chemotherapy, quote unquote, in the 70s, 80s, 90s, when there weren't a lot of good nausea medications. So there's a stigma to really not want to get therapy for their MDS, even though the therapies are probably starkly different. So I would say, yes, there's usually at least one or two things we can try, in some cases more. There are some side effects we are terrible at really treating or addressing, things like fatigue, among a couple others. So it depends on the side effect and to which degree, and in the context of which treatment. There are often some tricks, and that's where, you really have to rely upon the experience and expertise of your provider.
Thank you, Dr. Shallis. And what symptoms or side effects are important to tell your doctor about right away?
Anything that's bothering you, I would say, is something that your provider should know about. Because if it's bothering you, it's probably going to influence not only quality of life, but probably staying on a medication or a drug that hopefully will provide some benefit, whether it's in, a week, 2 weeks, sometimes it takes months to really get benefit. So if there's a side effect that is kind of bothersome, it should be vocalized, because unfortunately we do see many cases in which, a small, it's all relative, but, it's only slightly bothersome side effect that could be the harbinger of something that could be a bit more scary or a bit more dangerous if it's ignored. So we like to know about the small problems before they become bigger problems. It's hard to know the difference early on. So anything that's bothering you, warrants a phone call or telling your provider when you're sitting in front of them. But on the urgent side of things, if it's like an overnight sort of call or over the weekend, it's depends on the circumstances. But I would say if it's enough to bother you or get you a little worried in any small sense, what's the harm in a phone call?
Great answer. Thank you, Dr. Shallis. What do I need to change my eating habits during treatment?
Very common question. I'd say the commonest question we get is somewhat similar to that one is, well, what should I be eating? Are there any special diets, quote unquote, or special supplements, nutrients? I answer this question differently depending on who's in front of me. But, if there was something that made a difference, I would tell you, you have to eat this diet or you have to take this supplement. To one of the earlier questions, there are some things which can inhibit people actually, getting benefit from drugs. So always tell your provider about something that you are taking, over the counter or something that, is not relatively common. I would probably say, eat a well-balanced, healthy diet, easy for me to say. Some patients do run into issues with, like we talked about, some nausea or loss of appetite. But maintaining that caloric intake is somewhat beneficial. When patients lose weight, through no fault of their own, right? That can often make it difficult to stay on treatment, or if transplant is in the cards, to get through transplant a bit more safely. So in these cases, if side effects are really, kind of causing people to really not eat as much as they're used to, I usually ask my patients to maybe eat, smaller quote unquote meals, snacking throughout the day, grazing as we call it, and nibbling, getting some calories down to the point where it's not really overloading and stretching your stomach, but you're still getting some things in, always hydrate as best as you can. We are, myself included, notorious for not really drinking as much as we should, even though we think we are. So I would say those are, for the most part, the no-brainer things, but some people do need some counseling, and providers, whether it's, an MD, DO, or APRN, PA, even a nurse, I'm not trying to minimize the role of the nurse, but it's a team effort. People know how to help in small ways. So those are some tips, and, it's never wrong if there's a concern to at least ask for your team to really set you up with a dietitian or nutritionist. Those folks can be very, very helpful.
Thank you. We do have a comment from KT. Says, don't forget about the risk of grapefruit. Is a viz liver enzymes?
I see what you're saying. Yes, some people love their grapefruits, and there are some medications which do have a major interaction with grapefruit. Basically, the same sort of enzymes that metabolize grapefruits also influence the levels of some medications, which are chemotherapies, and even some other antibiotics and things, which can be very, very helpful. So yes, that's a great point. Definitely tell your team if you happen to love grapefruits. This is something that is often not asked, but if you like your grapefruits, please tell your people that you love grapefruits.
Okay, great. Thank you for that comment, KT. That's all the questions we have time for today. Thank you, Dr. Shallis, for taking the time out of your Saturday to present on this very important topic. And thank you, everyone, for joining us. If you have any questions that went unanswered, you can email our patient liaison, Audrey Hassan, at ahassan@mds-foundation.org. On behalf of the MDS Foundation, thank you and have a great rest of your weekend. This concludes our presentation for today. Thank you, everyone. And thank you, Dr. Shallis.